All right, welcome back. So obviously last week we talked about the blood. This week we're moving on to the next part of our discussion of the cardiovascular system, which is the heart. But before we actually get into the slideshow, since I was recommending that you purchase the Complete Anatomy app, I figured I needed to probably show you a couple things in the app. So when you open it up and then you click on models, this is what's going to appear. This is your basic whole body skeleton. But if you go down here to the left and click on models, you'll see that there's also a blood model, since that's what we talked about last week. And so you can see a little cutaway of a blood vessel here. And so you can see, I kept talking about the endothelium, which is the inside lining of a blood vessel. And so the endothelium is here. When we get to talking about blood vessels in the next module, we'll talk about the tunica intima, which is how this is going to be categorized when I click on it, and then the smooth muscle layer, the tunica media, and then also the tunica externa. But for now, the thing we've talked about, again, is those endothelial cells. Like I said, when you click on them, it's going to call that the tunica interna, but the reason for that is it's also including some of that underlying connective tissue. So when I was talking about it, I was just talking about these little cells here, and if we zoom in a little bit, you can see, so obviously here's one cell connected to its neighbors here, so here's another one, and those are their little nuclei. So those are your endothelial cells. They're lining the blood vessel. And speaking of the blood vessel, so in terms of the stuff that we talked about last week, remember that the fluid that the blood floats around in, or that the red blood cells float around in, that is your plasma. And so you see this kind of yellowish stuff here. That's the blood plasma. And so if you want to click on anything, you actually have to make the plasma disappear first. So we're going to hide the blood plasma. And now that we've done that, we can see some of the cells that we talked about last week. So obviously you've got your red blood cells here. And then these little yellow things, those are your platelets. So red blood cells, platelets, and then we start to get into our white blood cells. So we've got our neutrophils here. You can see those. Then what's next most numerous is our lymphocytes. So our lymphocytes are here. And then we got our monocytes. And then we have our eosinophils. And there aren't any basophils on here. The basophils, remember, only make up or only account for about 0.5% to 1% of your white blood cells. So they are very few in number, and so because of that, they're not actually on this model. So don't bother looking for basophils. As far as I can tell, they don't exist. So that's the blood model. And then if we go back to the full body model, there we go. So again, the thing that it'll, take those layers off. So when you first open it, this is what it's going to look like. And so since we're getting into the heart, if you want a really detailed model of the heart, much more detailed than we're actually going to go into, then you can just go to the first layer on the arterial system, and then you'll need to zoom in quite a bit. So I'll zoom in here on his chest. I'm going to make his sternum go away to make things easier to see. All right, so there's his heart. When you first open it, it might be beating, and if you just double click on the heart itself, it'll quit beating, which is helpful. So one of the things about the heart, before I show you cutaways, one of the things I can do is up here, I can click on heart, and then I can just isolate it, or I can hide others, either way. Okay, so we're going to hide the others. And so there's just a close-up of the heart. And actually, if I go back here, didn't mean to do that. There we go. So I go back here, and there's another way, rather than isolating it, if you hide the others, or whichever one I just didn't do, we'll turn on my skeletal system here. Okay, so again, got to go back and hide the sternum, sorry. Hide that. All right, so on the heart, so if we then isolate it, so we just did that. There we go. So if we isolate it, then what you can see, because toward the end of this chapter, we're going to talk about ECGs, and we're going to talk about the different phases of the cardiac cycle. So systole, diastole, and within those, we'll be talking about systole and diastole within the atria and within the ventricles, and all of that will make sense eventually. But what you can do is run through an ECG and what's happening during all of these waves. So we're going to slow this person's heart rate way down. We're going to put them at 40 beats per minute, which is as low as this thing will go. This would be somebody who's in really great shape, really elite level endurance athletes like your Olympic marathon runners or your Olympic cross-country skiers. And we're going to start this heart going. And so then you can see what happens in each phase of the cardiac cycle. It's still pretty quick, but you can obviously pause it at different parts of the cycle to see what's going on. And then you can do exercise. So you can go up to 120 beats per minute, which is not super fast. For somebody, your traditional college-age student, they're probably going to have a maximum heart rate somewhere in the neighborhood of 200. So in this case, they're working, but they're not, doing maximal exercise. So it is kind of a hard moderate to not quite vigorous exercise for a college-age student. But anyway, so if we make it go really fast, you can have the heart do some exercise and see what that looks like. All right, so let's go back. And so then once we've done that, if you want to do that, other things that we can do is that we can click on specific parts of the heart and then we can hide them. And so if you want to look inside of the heart, so I removed part of the wall of the right ventricle there so we can look at one of the valves we're going to talk about, which is the tricuspid valve there. So you can see inside of our right ventricle there. You can also look at this semilunar valve here, and then you can take off other parts, so we can hide that as well. We can get rid of some ribs so we can see better, and then you can see in there as well. So there's a number of different things that you can do. So I just wanted to make you aware that if you're playing with the Complete Anatomy app, there's a bunch of really cool stuff you can do with the heart, and then obviously it tells you what each of the structures are that you click on. So for example, we can find the individual flaps of this valve. So there's one. Leaflet is how it's referring to it in the app, but sometimes those are referred to as flaps. So you can find the different leaflets or flaps to the tricuspid valve. And there's the 3. So there's a bunch of cool stuff you can do with this. So just something to be aware of, so that you feel like it's a useful study aid, because this thing really does do much more than we would need it to, but it is a really useful and really interesting study tool. So certainly avail yourself of that. The other thing I should say before I move on too far, so there was a skin model. Obviously we didn't use it, but if you want to study from it, there's a skin model that has all the stuff we talked about. It doesn't get into as much depth on the different layers of the epidermis versus the dermis like we talked about. But it does have the different kinds of glands. It has the little papillary muscles here. It has the different tactile receptors. You got some of those. So it has all kinds of different stuff. That thing is really useful. And then there's one more model that'll be useful next week, which is our blood vessels. And so we'll get into this when we get into the next module. So there's a bunch of useful things in there for you to help you study. All right. So moving on then, on to the heart. So before we get into the anatomy of the heart itself, I want to tell you a quick story. So as you can see there, history fun. And so the question I have for you, and this obviously works a little bit better during a live class than it does just me talking to a PowerPoint, but this will suffice for now. So the question I have for you is, why is the marathon, which is a race of 26.2 miles, called a marathon? And if you're around people that are endurance athletes, often people have at least some sort of a passing familiarity with the story. The basic idea here is some guy ran that far and he died, which is the legend. So the fuller version of the legend is that it relates to actual historical events. So in the 400s BC, the Persians, so there's an empire based in modern-day Iran that spanned all the way into modern-day Turkey, and the ancient Greeks liked to antagonize them. And so the ancient Greeks were antagonizing the Persians in modern-day Turkey, and so the Persians got tired of it, and basically, and they attempted to invade Greece. And so those are the Persian Wars, which are the series of wars that take place over the span of about 50 years in the 400s BC. And so if you, and it is a dated reference now, but if you've ever seen the movie 300, that was based on the Battle of Thermopylae, which is during one of the Persian Wars. So in that case, the Spartans were fighting against the Persians. There's another, the marathon comes from another battle in the first invasion of Greece by the Persians. And so what happened was the Persians landed at a place in Greece called the Plain of Marathon. So the Persians have this massive force, and they are fighting primarily against the Athenians, so the Greeks who live in the city-state of Athens. That makes up the primary Greek defensive force that meets the Persians on the Plain of Marathon. And so the Greeks are vastly outnumbered. So they don't stand much of a chance, but somehow they're able to repel the Persians, and they win the battle, and they basically send the Persians packing back home. And so then after this unexpected victory, this messenger, one of the Athenians, his name is Phidippides, he, according to the legend, runs from the Plain of Marathon back to the Athenian Senate, and he shouted, quote, "Be happy, we have won," end quote, and then he fell down dead. And so the race, according to the legend, is to commemorate that run. So you run this really long distance. It's called a marathon because it's named for the Battle of Marathon. Run this really long distance that this messenger ran and then fell down and died right after running that. And I keep mentioning that it's a legend or it's a story because Phidippides doesn't show up in the historical literature until several centuries after the event. So he doesn't show up until, I think, the 200s BC, or maybe even after that. So several centuries after the event is the first that we hear of Phidippides doing this. And even when he does show up in the literature, he doesn't run from the Plain of Marathon to the Athenian Senate. Instead, he actually runs from Athens to Sparta to ask the Spartans for help on behalf of the Athenians. So basically, the Athenians anticipate meeting the Persians in this battle, and so they know they need help, so they go and ask the neighboring city-state with whom they fight regularly to ask them for help. Now that said, the distance from Athens to Sparta is 155 miles, and supposedly Phidippides covered that in 2 days, which is an ultra-marathon and still very impressive. That's a long ways to go in 2 days, but there's no mention of falling down dead or anything like that. So, and another thing to note is that 26.2 miles isn't even the distance from the Plain of Marathon to what would have been the Athenian Senate at the time. Instead, 26.2 is the distance from Windsor Castle in London to London's Olympic Stadium. And that distance of 26.2 miles was set at the 1908 Olympic Games in London. So the first modern games was in 1896, and then so a few games later we're in London in 1908. And so basically at the time, the marathon was just like a really long race. And so for the first several iterations of the Olympics, the marathon was just this really long race, and the distance varied. So it wasn't until 1908 when that is a convenient distance. So the marathoners started in front of Windsor Castle. They ended the race in London's Olympic Stadium. And the reason for the 0.2 is once they got inside of the stadium, race organizers basically, or Olympic organizers, wanted the finish line to be underneath the Queen's box inside of the stadium. So they actually extended the race to where the finish line was under the box. And so that's why you get the additional 0.2 on there for the total distance of the race. So again, people are familiar with the story of this guy who ran a really long way and died, but that's not what happened. And again, the distance is pretty arbitrary. It was basically, we need a long race. We're going to start in front of this castle. We're going to run up to the Olympic Stadium and also under the Queen's box, and then we're going to call that our marathon in commemoration of this race or this run that never happened. But anyway, and so that's commemorated also on Greek pottery and other places like that. So this is supposedly Phidippides making his run here. Although he's been squatting, he doesn't really have the physique of a distance runner, but apparently he was one. So why do I mention all of that in the heart chapter? The reason for that is that is the first mention of sudden death due to exercise in legend or in literature. And so if there's sudden death in athletes, it's almost always related to a cardiovascular event. So those account for the majority of sudden death in athletes. So we'll talk about in this chapter how the heart adapts to exercise a little bit, and then we'll also talk about some of the conditions that might be related to sudden death, some things that can stop the heart from beating. All right, so in terms of the heart anatomy, So what you've got here, this is a frontal plane cut. So you're just looking in on the heart there. So this is the right side of the heart, this is the left side of the heart, and I know, having just said that, you're like, well, that's on the left side of my screen and this is on the right side of my screen. So remember that when we're talking left and right, we're always talking in the patient or in the athlete. So this would be on the athlete's right, and this would be on the athlete's left. And so the right side of the heart is on the athlete's right, the left side of the heart is on the athlete's left. So one of the ways to think about the heart is, as you can see, is two side-by-side pumps. So there is the right side of the heart, and it is responsible for taking deoxygenated blood or receiving deoxygenated blood from the body and then sending that deoxygenated blood to the lungs. Now I'm going to use the term deoxygenated a lot, which means reduced oxygen content. The book is going to use oxygen poor and carbon dioxide rich. I guess oxygen poor is probably a better way of looking at it, although deoxygenated is just easier to say. One of the things I do want you to understand, though, and why that matters, so at rest, we're not going to extract all of the oxygen that we see, or that a tissue isn't going to extract all of the oxygen that it sees. It's going to just take a little bit of oxygen out, take what it needs to meet its energy requirements, and then the rest of the oxygen stays in the blood. And so that serves as sort of an oxygen reserve in case we need to, go from being sedentary to now I got to start running. I'm being chased by killer bees or something. I don't know. You got to run a long ways. And so with that, so the right side of the heart then takes that deoxygenated blood where the oxygen content is reduced, probably something in the neighborhood of 25%. It's going to receive that deoxygenated blood. It's again going to eject it to the lungs. Anything pulmonary deals with the lungs. So the pulmonary circuit runs through the lungs. Then that blood is going to drop off its carbon dioxide, because it's carbon dioxide rich. So it's going to drop off its carbon dioxide, which again is a byproduct of making ATP with oxygen. So as part of that whole process of breaking down fats, carbohydrates, and proteins to make ATP, we get carbon dioxide as a byproduct. And so that's going to accumulate, we got to get rid of it. And so we get rid of it by breathing it out. So we'll offload our carbon dioxide, we'll pick up oxygen, and so now on the right side of this diagram, but on the left side of the heart, so moving over, to not confuse you with right and left, moving over to this side of the diagram, you can see that the blood vessels change in color. They're red over here, so that's going to indicate oxygenated blood or oxygen-rich blood. So that's our oxygenated blood. That's going to return back to the left side of the heart, and then it'll go out to the body, which is the systemic circuit. So the blood flow to everywhere that is not the lungs is called the systemic circuit. So the right side of the heart then handles deoxygenated or oxygen-poor blood. The left side of the heart handles oxygenated or oxygen-rich blood. So there are 4 chambers to the heart. So there are 2 atria. So you can see the right atrium here, the left atrium here, and so the plural is atria, A-T-R-I-A. So there's 2 atria, a right and a left, and then there are 2 ventricles, a right and a left. So essentially 4 chambers to the heart. Right atrium, right ventricle on the right side, that deoxygenated side, left atrium, left ventricle on the oxygenated side. In terms of the heart's location, so thinking way back to 201, or when you get to 201 when we talk about it, so we talk about body cavities. And so there are dorsal and ventral body cavities, and all this stuff is in chapter 1 if you want to go back and look it up. But there are dorsal and ventral body cavities. Anything dorsal is on the back of the body, so that includes the cranial and vertebral cavities, so inside of your skull and inside of your spinal column. That the dorsal body cavity, or body cavities, house the central nervous system, so the brain and the spinal cord. The ventral body cavities, there are 2. So there's a thoracic cavity, which is the one that's relevant for us now. There's a thoracic cavity, which is everything inside of the rib cage, and then separated by the diaphragm here. So this is the thoracic body cavity, and then there's the abdominal body cavity. So the abdominal body cavity has the organs of digestion and filtration, basically. So your stomach, your intestines, your kidneys, your liver, your spleen, etc. All that stuff's in the abdominal body cavity. For now, we're talking about the thoracic body cavity, which again is inside of the rib cage. And the thoracic body cavity has at least 3 subdivisions. So there are 2 pulmonary cavities. So there's a right and a left. Those house the right and left lungs respectively. And then right in the middle between those 2 is something called the mediastinum. And so the mediastinum is kind of a middle body cavity. And so the heart is located inside of that mediastinum, inside of that middle body cavity. And so you can see this is a horizontal or transverse cut here. So you can see the lungs on either side. You can see your vertebral column and your spinal cord down here. And so then there's your heart sitting inside of that mediastinum, inside of that middle cavity. So in terms of the basic shape of the heart, so the heart has a base and an apex. So the apex is actually way down here. So the apex, usually if you think about an apex, so it's a point of something, but oftentimes if we think about an apex, it's on the top, right? So if we think about the pyramids, for example, or a pyramid, the apex of a pyramid is on top, but the heart is, at least with respect to the apex, the heart is the opposite. So its apex is down here, and then the base is over here. And so the base actually points at your right shoulder, the apex points at your left hip, so it's kind of angled inside of the chest cavity. The apical impulse, you don't need to know this, but the apical impulse is where the heart through the pericardial sac actually bumps up against the chest wall, and it's between your 5th and your 6th ribs on your left side. So you actually you can feel sort of that bumping sensation between your 5th and your 6th ribs on your left side. It is usually somewhere in the neighborhood, like right below your left nipple, but it's kind of hard to find. You got to palpate around a little bit to be able to find it. So like I said, I want to ask you about that, but that's what the apical impulse is. So the pericardium, or the pericardial sac, is the sac, if you will, that the heart sits in. So the pericardium has, broadly speaking, 2 layers. So there is the outer layer, which is the fibrous pericardium. And so if we, and actually I'll use the anatomy app for this. So we got the fibrous pericardium. So I'm going to bring up my full body model, and I'll turn on his cardiovascular system. So we're going to go layer 1 here. All right. Actually, I'm going to have to add layers to add the pericardial sac. So that's just the heart by itself with layer 1. Now we're also going to add some arteries here. So you can see we've added, the heart kind of got grayed out, so we've added a layer of tissue. There we go. So there is the fibrous pericardium, right? So that's the, basically it is dense irregular connective tissue, and so it's a bunch of collagen fibers running every which direction. It helps anchor the heart to the structures around it, and so it provides this sort of protective layer. And so what we're going to do is get rid of our fibrous pericardium, and so now we're into, so clicking back over here, we're into the serous component, right? So again, this is another one in Structure and Function 1. We talk about serous membranes, so those ventral body cavities, so again, both the thoracic and abdominal cavities, are lined by serous membranes. And serous membranes are a 2-layered membrane. So and you can see those layers here. So I'm going to bring this back up for a second. Oops. All right, so here is our fibrous layer of our pericardial sac, right? And so we got 2 layers of the serosa. So you got the parietal layer here, which attaches to the fibrous pericardium. And then you've got, my thing will come back, there we go, the visceral layer here. And so what happens is this serous membrane, or these serosa, as the plural of those are epithelial cells that are going to secrete serous fluid, which is a lubricating fluid. And so the heart sits in this pericardial sac, and then the serous membranes secrete this fluid. So the heart basically sits in this fluid-filled sac that allows it to expand and contract without rubbing on anything. So it gives the heart some room to work. And that lubricating fluid, again, so if you really are engaged in maximal exercise and you're really stretching the heart out, in case the actual wall of the heart were to bump up against that fibrous pericardium, that lubricating fluid is there to make sure that there's no damage done to the heart itself. So then going back to this. So we just got rid of the fibrous pericardium. So now you've got the parietal layer, which is going to be attached to that fibrous pericardium. And then we can hide that. And then we should have one more layer there, our visceral layer. There it is. So there's the visceral layer of the pericardium. All right, so that's how you can find those. Okay, so there's all of that. So know that the heart sits in the pericardial sac. It has a superficial layer that is the fibrous layer, really dense, tough connective tissue, and then inside of that you've got two serous membranes, the parietal serous membrane that again is going to be attached to the fibrous part of the pericardial sac, and then you've got the visceral serous membrane. And between the two of them, they secrete serous fluid, and again, lubricates and allows the heart to sit in a fluid-filled sac so that it can basically work unimpeded. It's not going to bump up against anything. It's not going to generate any friction or any of that kind of stuff. All right. So we've already talked about chamber sum. So here is an anterior view of the heart. And we've taken off the pericardium, all of the layers of the pericardium. So you're just looking at the heart here. So in terms of the chambers of the heart, so we've got, again, so what you're looking at, now you've got a frontal plane cut, and so you're looking inside of the heart. So again, this is the right side of the heart over here, left side of the heart over here. So you've got the right atrium, left atrium, right ventricle, left ventricle. So other things to be aware of. So again, the right side of the heart is going to receive deoxygenated blood. So all of that deoxygenated blood dumps into the right atrium of the heart. And so there are three major blood vessels that dump into that right atrium. So you've got the superior vena cava. And so you can see the superior vena cava is right here. So it brings blood back from the entire upper body. So all the blood returning to the heart from the upper body comes in the superior vena cava. As you might have guessed, all the blood returning to the heart from the lower body comes in this inferior vena cava. And then the coronary sinus, which is not pictured as far as I can tell, the coronary sinus returns blood from the cardiac circulation. So your heart has its own circulation to supply the myocardium, the heart muscle, with blood. And so then that blood, once it's deoxygenated, also returns to the right atrium, but rather than dumping into the superior vena cava, it has its own spot in the wall of the right atrium where it dumps deoxygenated blood back in. So these two are the primary great vessels, or are the great vessels, that bring blood back to the right atrium. And the coronary sinus, again, returns deoxygenated blood from the cardiac circulation. Left atrium there. So one of the things between the ventricles to notice is, so again, here's our right ventricle, and then our left ventricle over here. So notice how much thicker the wall is of the left ventricle. This is your interventricular septum, so it separates the right and left ventricles. But that included, notice how much thicker the wall of the left ventricle is. That's because the left ventricle is going to eject blood out to the body through the aorta. So this is your aorta up here. And so because it has to send blood out to the whole body, whereas the right ventricle just sends blood to the lungs, the left ventricle has to generate quite a bit more pressure, has to be able to contract quite a bit harder, and so its structure reflects that. So it has a lot thicker wall to it than does the right ventricle. So, and I'll hit on this again, but just the path of blood flow through the heart, because that is one thing I want you to be familiar with. So the way blood flow through the heart works is that we're going to get deoxygenated blood coming back, again, superior vena cava, inferior vena cava, coronary sinus. They all dump their deoxygenated blood into the right atrium. The right atrium is then going to contract, and that's going to push blood down into the right ventricle, down here. Then it's going to contract, and that's going to push blood here into the pulmonary arteries. So there's a right and a left pulmonary artery. That then directs blood out to the lungs. Blood drops off carbon dioxide, picks up oxygen, returns back to the heart via the pulmonary veins. So there's two on the left, two on the right. Those dump into the left atrium. Left atrium is going to contract, push blood down to the left ventricle. Left ventricle contracts, pushes blood out through the aorta to the rest of the body. So blood flow through the heart then, right atrium, right ventricle, lungs, left atrium, left ventricle, body. That's the basic version of circulation through the heart. Other things on there, and we'll talk about this more when we get to blood vessels next time, but in general, basically everywhere other than here, arteries carry oxygenated blood, okay, or oxygen-rich blood to use the book's terminology. Veins carry deoxygenated blood, so oxygen-poor blood to use their terminology, right? But that is actually reversed here in the heart. So in this case, you've got the pulmonary arteries, which are carrying deoxygenated blood. So another way to think of arteries is that arteries carry blood away from the heart. And then veins return blood back to the heart. So in this case, these the pulmonary veins, the left and the right, where's my little thingy? There it is, the right pulmonary veins. So the pulmonary veins carry oxygenated blood from the lungs back to the heart. So the pulmonary arteries are the only arteries in the body that carry deoxygenated blood. The pulmonary veins are the only veins in the body that carry oxygenated blood. But if you don't want to mess with these two exceptions, you can just think of arteries as vessels that carry blood away from the heart. Veins carry blood back to the heart. All right, so let's talk about valves. So there's two major sets of valves. You have the atrioventricular valves and then the semilunar valves. So the atrioventricular valves tell you where they sit. So they sit between the atria and the ventricles. And the job of both sets of valves is to prevent backflow of blood. So I just mentioned on the last slide the way that blood flows through the heart. It only goes one way. And in fact, if it goes the other way, that's a problem, as you would imagine. And so it is the job of these valves to prevent that backflow. So that's their primary job. So because we have a right atrium and ventricle, you've got one valve between those two, and then we have a left atrium and ventricle, and you've got another valve between those two. So the tricuspid valve, the cusps refer to how many flaps those valves have, and so tricuspid means it has three flaps or three cusps, right? And so the tricuspid valve is between the right atrium and the right ventricle. So if we go back here, here's our tricuspid valve, so between our right atrium and right ventricle. And so what's going to happen is when the right ventricle goes to contract, that's going to cause that valve to snap shut. And so as that chamber is contracting, it can't push blood back this way because of the tricuspid valve being closed. So instead, that blood flow can only go one way, can only go out the pulmonary arteries. So specifically, it starts in the pulmonary trunk first, but can only go out toward the pulmonary arteries. Okay? So those valves, again, prevent backflow. The tricuspid valve is here. The other valve is the bicuspid valve because it has two cusps. Sorry, so bi means two, right? Also known as the mitral valve. So the mitral valve and the bicuspid valve are the same thing. So the mitral valve or the bicuspid valve is between the left atrium and the left ventricle, and again, it serves the same purpose. So whenever the left ventricle contracts, that mitral valve is going to snap shut, and so blood can't flow back into the left atrium, and instead has to leave the heart, has to go out into the aorta. So those are your atrioventricular valves. So there were a couple other things on this slide. So you can see the chordae tendineae and then the papillary muscles. So the chordae tendineae are these little guys, these little white things here. I've seen them compared to the like strings on a parachute. So the valves themselves being the parachute, and then the chordae tendineae being the strings on a parachute that attach them to you. I don't know if that's helpful for you. But basically what those do is the chordae tendineae anchor into the papillary muscles, these little things here. And so that, again, serves as an anchor point so that the valves, because the valves are under really extreme pressure, especially the mitral valve on the left side of the heart. So to keep them nice and tightly closed and keep them anchored to the heart wall, that's the job of combination of the chordae tendineae and the papillary muscles. So those provide an anchor point so that we don't get basically a splitting of the cusps, or we don't get to where the cusps bulge backwards, if you will. And there's a better term for that I'll use here in a second. All right, so those are our atrioventricular valves. So again, sit between the atria and the ventricles. Tricuspid valve on the right, mitral valve or bicuspid valve on the left. The way that people typically remember that, or the way that I'm familiar with, the mnemonic for that is try to be right. And so the tricuspid valve is on the right side, the bicuspid or mitral valve is on the left. Then our semilunar valves, so those sit between the ventricles and the whichever great vessel it is that they are ejecting into. So the pulmonary semilunar valve sits between the right ventricle and then the pulmonary artery, right? So, or pulmonary trunk more specifically. So you've got, again, right ventricle here, the pulmonary semilunar valve here. So the right ventricle is going to contract. It'll push blood past that valve into the pulmonary arteries, and then the right ventricle is going to relax. And so when it relaxes, so after contracting, pushing up this way, when it relaxes, that's going to create a vacuum. And so that would tend to pull blood back this way. But to prevent that, those semilunar valves are going to snap shut and, again, not allow that backflow. So the job of the pulmonary semilunar valve is to prevent backflow from the pulmonary arteries back into the right ventricle. On the other side, we have the aortic semilunar valves. Oops. There you go. On the other side, we got the aortic semilunar valve. And so the aortic semilunar valve is right here. And so same concept on this side. So the left ventricle is going to contract, push blood out into the aorta, but then when the left ventricle relaxes, that creates a vacuum. And so the aortic semilunar valve is going to snap shut to prevent that backflow back into the left ventricle. So the job of all those valves then, again, is to prevent backflow. The atrioventricular valves prevent backflow from the ventricles back into the atria. The semilunar valves prevent backflow from either the pulmonary arteries or the aorta back into the right ventricle or left ventricle, respectively. And so you can see the way the valves look there. They connect to each other really closely. So again, they're going to prevent that backflow. All right, so let's talk about heart sounds. So as I'm recording this, Valentine's Day has just passed. And so maybe you were able to spend Valentine's Day with your significant other, and maybe you two watched, I don't know, some kind of romantic comedy or something, some kind of Valentine's Day appropriate movie. And maybe you laid your head on their chest and you listened to the sound of their heartbeat, right? Ah, it's romantic. And when you listened to their heart, you heard two sounds, thump, thump. Often those are referred to as lub-dub or lup-dup, either way. So there's two sets of sounds. And so what you're hearing there are the closing of those valves we just talked about. So the first sound, the lup or lub, however you think about that, that first sound is the closing of those AV valves. So the tricuspid valve and the bicuspid valves closing at the same time, or close enough to the same time. So that's the first sound, is the closing of the AV valves. And then the second sound is the closing of the semilunar valves. So as you're listening to their heart, thump, 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 what you're listening to really are the sounds of their valves closing and preventing backflow in their heart. So there you go, listening to the heart doing its job. But those valves don't always work perfectly, as we know. We're all designed a little bit different, and sometimes things go awry. And so if there's a problem with those valves, those are referred to colloquially as heart murmurs. And so one of the more common heart murmurs is a mitral valve issue. So it's on the left side of the heart. And so if there's a problem with the mitral valve on the left side of the heart, the common, or we'll go with common. The common way to describe that is that there's a click in the middle of the contractile phase, or it's called a mid-systolic click. So you're going to get kind of a clicking sound as the left ventricle is contracting. And so that indicates that there's some valve insufficiency. It's not doing what it's supposed to be doing. And so there's a couple different things that can happen. One, or the first one, is prolapse. And so if you've got a prolapsed valve, what that means is that the valve itself is bulging into that backflow, or the chamber where the backflow would occur. So in the case of the mitral valve, a mitral valve prolapse is going to kind of bulge back into the left atrium this way. And then if you've got regurgitation, you actually have, or don't have, a tight seal on those cusps or on those flaps on the valve. And so that's allowing backflow, in the case of the mitral valve, it's allowing backflow from the left ventricle back into the left atrium. And so sometimes you'll hear these murmurs described as a whooshing sound. As I mentioned, sometimes you'll hear it described as a clicking sound. But based on the particular sound, somebody with a really trained ear, so a cardiologist and even some GPs, are going to be able to have a pretty good idea of what might be going on. So as part of my grad athletic training program now like 15 years ago, that was one of the things that we had to do, is to listen to different recordings of different heart sounds and be able to figure out what the murmurs were, and I was terrible at it. So don't ask me if that's the particular issue that you have, but they do have characteristic sounds that are a little bit different with each. I could tell you they were different, I just couldn't tell you what each one meant. And so traditionally these heart murmurs had been a cause for disqualification from athletic participation. So for example, when I was a kid, about middle school, one of my best friends at the time, we were all getting ready to play football because, grew up in Texas and that's what you do, you play football. So we were all signed up for football, all getting ready to play in 7th grade, which is the first year you can play. And my good friend went to the doctor to get his physical and came back and was like, I can't play. They told me I have a bad heart and I can't play. And so ultimately, through discussion, it came out that he had a mitral valve. I think he actually had a regurgitation. This part, it was a long time ago, so I don't know the specifics, but there was a problem with his mitral valve. And so it would be relatively common if somebody had mitral valve insufficiency to disqualify them from athletics. And the question is, well, why? And the answer to the question is, well, if the left ventricle is contracting, ejecting blood out into the aorta here, but there's some backflow into the left atrium, well, that's going to send what's called your stroke volume down. The stroke volume is the amount of blood ejected from that chamber with each beat. So typically when we talk about stroke volume, we're almost always talking about the amount of blood ejected from the left ventricle with each beat. And so their stroke volume is going to go down because they're losing some of that blood back into, so as backflow, into that left atrium, not all of it's going out the aorta. And so to compensate for that reduced stroke volume, the heart is going to beat more times because it's trying to still churn the same amount of blood out. It's trying to still meet the demands of the working muscles by supplying them with oxygen. And so it's going to increase heart rate in response to that decrease in stroke volume. And we'll talk about this in more detail in the next heart lecture, but just to kind of prepare you for some of the stuff that we're going to talk about. So to compensate for that decreased stroke volume, you're going to see a big increase in heart rate, depending on the intensity of the exercise. And so there's this thought, or it is possible, that they're then going to be working at much higher heart rates for the same relative intensity, or not the same relative, the same absolute intensity of exercise. And so as a result, they are more likely to have an arrhythmia, where you've got so much electrical activity in the heart trying to keep pace with that really high heart rate that it can throw off the rhythm of the heart and cause it to just to move into fibrillation, which is where the heart's just kind of shaking, right? It's not doing what it's supposed to be doing. So fibrillation is basically you're just getting this disorganized contraction here through the left ventricle. Maybe this part's contracting, then this part, as opposed to normally your left ventricle contracts bottom up to wring blood out. And so because those really high heart rates potentially could lead to or could predispose somebody with a heart murmur to arrhythmias, athletes were disqualified from athletic participation. Starting in 2015, the American College of Cardiology changed that position. So athletes with a mitral valve prolapse or mitral valve insufficiencies often can continue to play, but the recommendation from the American College of Cardiology, is that they should, especially if they have regurgitation, that they should undergo reevaluations every year with stress testing. And so if they get through those and everything looks okay, there's no irregularities in their heart rhythm, then they're allowed to continue to participate. So heart murmurs aren't completely a reason to disqualify athletes anymore. Some athletes still get disqualified, but I think somebody like the kid that I knew back in 7th grade, I think he probably would not have been disqualified, but under the newer guidelines. All right, there we go. All right, so here's the pathway of blood flow through the heart. And I'm just going to do it on the picture to make life more interesting. But here's the actual wording. So So you got deoxygenated blood coming in the superior vena cava and inferior vena cava. They're going into the right atrium. The right atrium is going to contract. That blood is going to pass through the tricuspid valve into the right ventricle. So that's where we are over here. The right ventricle is going to contract and eject blood past the pulmonary semilunar valve into the pulmonary trunk and then eventually into these pulmonary arteries. We're going to drop off carbon dioxide. We're going to pick up oxygen. Now we have our freshly oxygenated blood or oxygen-rich blood. And then we're going to come back into the left side of the heart. So we're then going to dump that freshly oxygenated blood via the pulmonary veins into the left atrium. It's going to contract. That's what we got going on here. It's going to then push the blood through the mitral or bicuspid valve right there. Then the left ventricle is going to contract and eject blood through our aortic semilunar valve out into the aorta, which then the blood goes out to the rest of the body and then returns, start the whole cycle again, back at the superior and inferior vena cava. So that's the pathway of blood flow through the heart. All right, so a couple more things. The first one here is our coronary circulation. So how does the heart muscle itself get the oxygen that it needs? And the answer to that question is the heart has its own separate circulation. So that's called the coronary circulation. So what ends up happening there is that, and I'll actually back it up to, I don't know, pick a different picture. Go here, kind of. None of these pictures are super great. We'll go back here. All right, so what's going to happen is that, so again, the end of all the blood flow through the heart stuff is that left ventricle contracts, ejects blood out here into the aorta. Remember that when the left ventricle relaxes, that's going to tend to create a vacuum, which would pull blood back into the left ventricle, but you're going to get a closing of the aortic semilunar valve. And so the aortic semilunar valve is somewhere approximately here. And so again, that's going to prevent backflow of blood into the heart. And so when that blood gets pulled back, it's going to slam up against that aortic semilunar valve, and instead, it'll get directed into the coronary arteries. And so the coronary arteries are what supply the myocardium, the heart muscle, with its blood and thereby with its oxygen. So there's two coronary arteries. There's the left coronary artery and the right. The right coronary artery supplies the right atrium and the right ventricle. The left coronary artery supplies everything else, including the interventricular septum. So the left coronary artery is bigger and supplies more of the heart. The coronary veins return deoxygenated blood back to the right atrium eventually. So they're going to, we circulate oxygenated blood past the myocardium, drop off oxygen, pick up carbon dioxide, and then we'll return that oxygen-poor blood back to the right atrium, and then continue that cycle. So that's how the heart gets its circulation. All right, so the last thing I have for you today, because again, as I'm recording this, it's February, and so, you know, we're getting snow every few days, which is brutal. But one of the things I was listening to a podcast recently, and it was a hockey podcast, if I'm being honest. It was a hockey podcast, and they were talking to a guy who lives in the Northeast. And so a bunch of snow had fallen in the Boston area, and so they were talking about shoveling it. And so they're like, oh, that's the dangerous snow too. Like that's the really heavy snow. That's the heart attack snow. And so obviously what they're referring to is that really like wet, heavy snow. And that snow they identified as being particularly dangerous. And so they were talking about this guy preparing to go shovel. I think they'd gotten 13 inches or something, which is a lot of snow. And so he was saying, or they were saying, you know, make sure you get a good warm up in because that'll kill you. And so they're right. I mean, potentially, yeah, that could initiate a heart attack. So my question for you is, why is that the case? Like, why can snow shoveling, or really any arduous physical activity, why does that tend to trigger a heart attack and thus potentially kill you? And the answer to that question deals with how the heart uses its oxygen. So again, the myocardium is the heart muscle, so we're talking about use of oxygen by the heart muscle itself. So there's an important term on here, which is AVO2 difference. So the A refers to the arterial side, so the oxygenated blood. The V refers to the venous side, so the deoxygenated blood. And then O2 is obviously oxygen. and then the difference between the two. So AVO2 difference stands for arterio, because we're talking about arteries, arteriovenous oxygen difference. And so what does that mean? That is, or that deals with how much oxygen is extracted from the blood by a particular tissue. So, for example, your skeletal muscles, the muscles like your biceps, your hamstrings, etc. At rest, those muscles only take out about 25% of the oxygen that they see from the arteries around them. So they don't use up very much oxygen. So then during exercise, one of the things that they can do to produce ATP, to produce energy at a higher rate, is they can simply extract more oxygen. So rather than taking out 25% of the oxygen that they see, they can extract 50% or 75%. So that's called expanding the AVO2 difference. You're just extracting more oxygen. So skeletal muscles can do that. They can simply extract more oxygen. And in addition to that, we can also dilate or open up the blood vessels to those working muscles so that we can increase overall blood flow or blood volume and expand the AVO2 difference. So the combination of the two, increasing blood volume or blood flow to those muscles, plus the muscles themselves being able to extract more oxygen, leads to them being able to produce more energy, more ATP, aerobically. But in the heart, the myocardium, myocardium is similar to skeletal muscle, but it is a little bit different. So one of the things that heart muscle does is at rest, it extracts about 80% of the oxygen that it sees. So it extracts almost all the oxygen that it sees, 4/5, even at rest. And so that means once we start exercising, the heart muscle doesn't have much more oxygen that it can extract because it's already almost maxed out the AVO2 difference, unlike skeletal muscles. So for the myocardium then, the way to get more oxygen to it, the only way really, is to increase blood flow. And so that's dependent on being able to dilate the blood vessels in the heart so that we can increase flow to them. And so what can happen in the case of a heart attack, the basic mechanism with a heart attack is that one of your coronary arteries, so in this case we're looking at the left coronary artery or a branch off of the left coronary artery. So the coronary arteries across the lifespan are going to start to accumulate plaque in them. So often that plaque is associated with a high intake of saturated fats. That can then lead to accumulation of these plaques. And then those plaques do a couple things. One, they cause the artery to harden, so it's not as stretchy as it was before. It's not as elastic or extensible as it was before. And in addition to that, they also close down the diameter of the blood vessel. So the blood vessel can't really dilate. It can't really open up there. And so, for example, if you've had any relatives, like some of mine, one of my grandmother on one side went in for heart surgery at one point, and I think she said her, one of the coronary arteries, I don't remember which, I think the left, was 93% occluded. And so what that means then is that this blood vessel is 93% blocked. So only 7% is open for blood flow. So why that matters to this discussion is if we start exercising, if a person with that much plaque buildup starts exercising, well, all of the heart musculature, all the myocardium is going to need more oxygen. And again, the only way to get it more oxygen is to increase blood flow. Well, if I'm down to what is effectively a one-lane highway here, I can't get very much blood flow to everything downstream of that. So here's where the plaque buildup is. So everything downstream of that, I'm really limited in the amount of blood flow that I can get to that working muscle. And so if we then go and do some really strenuous exercise, like shoveling really heavy snow, those myocardial cells are going to need a dramatic increase in oxygen supply that I can't meet because I can't increase blood flow to them because of this plaque buildup. And so then what happens is they start to work anaerobically, and as we'll talk about next time, heart muscle is not good at working anaerobically, basically can't. And so the result then is you're going to get where these heart muscles cells are going to go into spasm, and then that'll throw off the rhythm of the heart. And so then you get what I was describing earlier, which is fibrillation, which is where you're just going to get sort of this random electrical activity and random contraction of the muscle of the heart, and not the orderly contraction that we need, in the case of the ventricles, from the bottom up, wringing blood out of the ventricles and into the aorta. And so the reason then that exercise can cause a heart attack is because to provide the working musculature with the oxygen that it needs, we have to increase blood flow. But if you have some sort of an occlusion or closing down in the vessel because of plaque buildup, then we're not able to get enough blood flow to the heart muscle. That's then going to ultimately lead to the death of that the heart muscle downstream from that blockage site. And so then that causes fibrillation, throws the heart off its rhythm, and if the heart's not rhythmically contracting, that means the heart's not beating anymore, and then as the rest of your tissues don't get oxygen, like your brain, then those tissues die, right? So that's where exercise can initiate a heart attack. Now, another thing that can happen if somebody just like has a heart attack, one of the things that can happen is there's a clot or something, and which you can see is what's happening in this picture. There's a clot that gets stuck and completely cuts off or completely occludes blood flow distal to that. And so now this muscle isn't getting, or this myocardium isn't getting any blood flow at all, so it's not getting any oxygen, so then those heart muscle cells die, again throws off the rhythm of the heart, and then that can lead to the fibrillation and eventual death. So that's why shoveling snow is dangerous, because the only way to get more oxygen to the myocardium is by increasing blood flow. Can't really expand the AVO2 difference much. So the technical name for a heart attack is called a myocardial infarction. If the person survives that, there's a couple ways to deal with that. One of them is a stent, and so that's what you see pictured here. So they'll have a little balloon with a little wire mesh around it. They'll slip that into the area of the plaque. They'll inflate the balloon, and then that mesh will actually compress that plaque, and then they just lock the mesh in place, and so now you've manually opened up the blood vessel. The other thing is bypass, and so if we've got a bypass, what we're going to do is take a vessel from somewhere else. So you can see this one's a relocated vessel from inside the chest wall. Sometimes they'll use some from the legs, which you can see over here. And so what they'll do is they will attach that blood vessel, in this case this one's going from the aorta, and they'll just kind of go around that blockage site. So it's kind of like if there's a big accident on the highway, just building another couple lanes around that accident, that's what a bypass does. And so this person has a double bypass because they've got one on the left side and then one on the right side. Sometimes you'll hear people have a triple bypass. That means they went around 3 parts of the artery. So that's what the different bypass things mean. Single bypass, you went around 1 blockage. Triple bypass, you went around 3 of them. All right, so that's all I want to cover today. Next time we'll get into the rhythm of the heart, and we'll get into some of the external controls of the heart. So we'll see you next time.